Good to go? Okay. Thank you for all coming tonight. So I'm Seniha Ozudogru, and we are going to talk about chronic daily headache. And we'll start with what's the diagnosis, what is the difference, how important is it, the episodic headache, chronic headache, or intractable headache, or not intractable headache, and then the name of the syndrome. And we also always think about, is this a primary headache or a secondary headache? So we'll talk about the details of this. So what's chronic headache? The definition of chronic headache is a headache more than 15 days a month, more than 3 months, and the diagnosis becomes chronic headache. And when it comes to specific syndrome, which kind of syndrome is this? It can be chronic migraine, it can be chronic tension type headache, hemicrania continua, and new daily persistent headache. There are other headache syndromes, primary and secondary headache syndromes, but tonight we'll talk about these four common ones, especially for female population. For chronic migraine, when it comes to diagnosis, yes, the person should have more than 15 days of a headache, more than 3 months. Also, they require to have 8 days of migraine in between these 15 days of headache. Not additional 8 days, but 8 days of these 15 headache days should be a migraine. The transformation of chronic migraine from episodic migraine is very common, unfortunately. In general population, over the course of 1 year, there are 3% of people with infrequent episodic headache. Their headache frequency increases and it progresses into chronic migraine. And this is in general population. And if we count this in neurology clinic, the number will be higher up. And what is intractability? So intractable headache means that if someone failed 2 preventive treatment from the 4 main group of medications, which are beta blockers, anti-epileptic medications, tricyclic antidepressants, and calcium channel blockers, then their headaches can be intractable. They also required to fail 2 different rescue medication, abortive medication. It can be a triptan, it can be an ergotamine, plus a non-steroidal anti-inflammatory medication. If someone has contraindications that they cannot take some of these medications, that counts as well, that it will be intractable headache. So the list on the right is one of my patients. So we usually see when our patients come to us, it's not the 2 different medication that I don't think it's very not unfamiliar for you that you fail multiple medications, and it makes the diagnosis intractable headache. Okay, so why it is important? Why the diagnosis of episodic or chronic is important? Because we use different treatment modalities. If someone has episodic migraines or episodic headaches, they require only rescue therapy. The rescue therapy is the medication you take to stop the attack. But if you have chronic headaches, then you need preventive treatment. And preventive treatment is the medication or the treatment you use to decrease the frequency of the headache, also the severity of the headaches. If person has a chronic headache, then probably you will require both of them. But if you have episodic headaches, you don't have to be on a preventive medication. And what causes chronicity? So the numbers are very high that people with episodic migraines, 6% of these low frequency episodic migraines goes into high frequency or chronic migraines within a year. And one of the reasons is untreated episodic headaches. So you can have 6 or 8 migraines a month, and if you kind of ignore it and you don't get treatment, it's life, it's busy, and then you kind of try to get through it with ibuprofen and Tylenol, some over-the-counter pain medications. If you don't get adequate treatment, that episodic migraine will highly likely turn into a chronic migraine or chronic headache. This other thing is medication overuse. We'll talk about more details about what's medication overuse headache, but basically if someone taking their rescue medications more often than they are supposed to, it can cause medication overuse, which can cause medication overuse headache, which is chronic headache. Caffeine overuse. It's always a debate, does caffeine help? Does caffeine causes more headaches? So caffeine can help for episodic headache. If you are having an attack and you take some medication with caffeine, it can help. But if you are having chronic headaches and you take caffeine, very high amount of caffeine, usually we put the bar as 200 milligram of caffeine, and very often, almost every day, that it actually causes caffeine overuse headaches, and it stops working and it starts giving you more headache. Obesity is another reason. Yeah.
Did you say that was 200 milligrams?
200 milligram of caffeine.
Okay,
Yep.
thank you.
Obesity is another reason, is another risk factor to have chronic headaches. The reason is obesity causes constant stress on the body, and with this constant stress, your body has a high sympathetic flow, which causes more headache. Also, it increases the inflammatory cytokines to release, like CGRP, and it causes more headaches, and it can cause chronicity. And comorbid psychiatric illnesses, anxiety, depression, PTSD, there's a high risk to progress into chronic headaches. Inconsistent sleep cycle, insomnia, there are other common ones. We'll talk about a little bit more detail on those. Comorbid pain disorder. If you have neck pain, back pain, fibromyalgia, it's high likely your headaches will turn into chronic migraines or chronic headaches. History of head and neck injury, that's another risk factors found to be high in people with chronic migraine, and major life-changing events. Death in the family, diagnosis of cancer or divorce or moving from another place. These are important to look into why you are having chronic headache and then try to eliminate. But the other reason these are important, if someone has chronic headaches from episodic headaches, or if someone doesn't have a headache and then start having headaches, we look for these things and see if there is any reason why your headaches are turning into chronic headaches. If we don't find any reason, then we have to be cautious, and we should consider about, is there any structural disease or systemic disease going on that without other reasons that you are having chronic headaches.
If I could go back to the psychiatric illnesses, has there been good study work done to diagnose whether the psychiatric problem getting worse or the headache getting worse? Yes. Does the chicken and the egg thing?
It's a chicken and the egg things, unfortunately, and we'll talk about those. Yep. Okay. Couple slides after, we will talk about a little bit more detail on that. But there are some epidemiological studies.
Okay.
Medication overuse headache. So what's medication overuse? If you are taking a simple analgesic, meaning over-the-counter painkillers like ibuprofen, Tylenol, naproxen, if you are taking them more than 15 days a month, more than 3 months, the diagnosis that you are having medication overuse. And if you are taking a combination analgesic like the butalbital combination or Excedrin, Fioricet, Fiorinal, or a triptan or an ergotamine, more than 10 days a month, then it causes medication overuse as well. Not every medication overuse causes medication overuse headache, but it's a high risk that it will go into medication overuse headache. And there are 3 main group of medications that in an epidemiological study they looked into: opioids, barbiturates, and triptans, and they look into the risk factors of turning into medication overuse. And with opioids, unfortunately, the risk for chronification of migraine was very high after taking an 8 days of opioid use in a month. When it comes to barbiturates like butalbital combinations, Fioricet, Fiorinal, the risk is increases progression of chronic migraine from episodic migraine increases after 5 days use of these medications in a month. And they also looked into triptans, and triptans induce migraine progression, the chronicity, and it only showed in people with frequent headaches, more than like 10-14 days of the headache. So the risk is a little bit lower than when you look into opioids and barbiturates use. Comorbid psychiatric illnesses, and we'll come to your question. So the prevalence, the diagnosis of depression is about 40% in people with migraine whereas it's 16% in people without migraine. So the depression risk is higher if you have a migraine. And if you have chronic migraine, the risk increases further as compared to episodic migraines. And if you have a migraine with comorbid depression and anxiety disorder, then the disability, its effect on your life, migraine-related disability increases as well. And it's also shown that the depression may be a risk factor for chronification. So it's both-sided. If you have a depression, then depression will make your migraines more, it's high risk that it will make your migraines more chronic, more often. And if you have a migraine, you will high likely have depression and anxiety. So it's both-sided. That's why it's important to treat both disease. Depression or anxiety, psychiatric illnesses by itself is not the reason for headaches. But if you have a headache disorder like migraine, and on top of it you have these diseases, it will make it more chronic and sometimes can be a reason for intractability. So that's why we have to treat both. Both of them are very important. Does it give you an answer?
Yeah, that does help. Would you mind going back to
Sure.
that bullet on the last slide? Okay, thank you.
Sleep. So we all know that if you are unable to sleep, if you if we cannot sleep more than a couple hours, it's high likely the next day you will have a headache, right? But it's also true if you sleep longer hours. So the main thing is the variability of the sleep. People with shift works, like night shifts, day shifts, and mixed shifts, that they are high likely to have migraines, chronicity because of the change in the sleep schedule. Having a good sleep schedule is important, and changes in the sleep cycle will increase the risk of chronification for headaches. Others are the sleep disturbances, and what causes sleep disturbances, like nightmares, vivid dreams. If someone has PTSD and having nightmares, and nightmares disturb your sleep every night, even if you are sleeping 8 to 10 hours, the quality of your sleep very low, then it will cause chronification of the headache. So we have to treat the nightmares. Snoring, if someone has sleep apnea, unless we treat the sleep apnea, it will be very difficult to control the headaches. And there are some common sleep disorders that it's found to associate with migraines. Restless leg syndrome, insomnia is the more common one, daytime sleepiness, and poor sleep quality.
Good question. Is there like a number for how much is too much sleep? For me, so I have chronic daily headaches, and so I'm just tired all the time, and so I sleep 10 hours on average, sometimes more. Am I pushing that threshold of too much sleep?
When it comes to how many hours you need to sleep, it's based on your daily routine and how active you are and what kind of job you do, how you spend your day, and it's more personal. Some people can have 6 hours of sleep and then they will be good. On the other hand, some people, if they don't sleep or if they sleep less than 8 hours, it will be too difficult for them to survive. In general, the average is like 8 hours.
Do you mind if I throw something in? My psychiatrist recommended a really good book. It's called No More Sleepless Nights.
Okay.
And it talks about tracking your sleep times and lengths so that you can find your natural sleep and wake time, and the amount of sleep your body naturally needs is great.
Okay, thank you. I wrote it down.
Perfect.
Appreciate it.
Thank you. Okay. Trauma. So what is important here is mild head injury compared to uninjured people increases the risk of chronic headache. So we sometimes ignore some mild head injuries, like you didn't lose your conscious, but still you had a head injury, and it can increase the risk of chronification of the headaches. And the injury can cause new onset of the headache, or the injury can worsen the headache, that with the episodic headache, or low frequent headaches can become high frequent headaches, or it can turn into chronic headaches. Sometimes it presents as headache only. Sometimes it can be a part of post-concussion syndrome. And post-concussion syndrome associates with the symptoms associated with dizziness, imbalance, unable to sleep, insomnia, mood swings, personality changes, and cognitive decline, memory problems. It all comes with the concussion after the concussion, that it's post-concussion syndrome, and headache can be a part of that, or it can be only symptoms after the injury. Is there any difference when you have episodic headaches to turns into chronic headaches? So it's very common that I hear from my patients that they say, my headaches used to be more severe, or I used to have aura, now I am not having aura as often. I have these normal headaches. So there is no normal headaches, right? Headache is always abnormal. There is no such a thing as a normal headache. So what happens when your headache becomes chronic is you can start having non-migrainous headache in between your migraines. So you might start having headaches that they doesn't have migrainous feature, which used to be like only migraine headaches. Or you used to have a throwing up episode all the time with your headaches. Now you are not having those headaches very often. They are very less often happening, but you are having this maybe low, milder headaches that it doesn't associate with those symptoms. With the chronification, it's shown that that changes can happen. Other changes can happen is the cutaneous allodynia. Allodynia means feeling pain with non-painful stimuli, like touch hurts, cold hurts, your hair hurts, your teeth hurts, and you don't like to put your jewelries on, you don't like to have a necklace on, because it's not the pain, it causes a discomfort. You don't like to get a hug from your kids when you have a headache because it bothers you. You don't want anyone to touch your head because it bothers you. That's called allodynia. And allodynia associates with chronic headaches. So you won't have allodynia with episodic headaches. When you start having chronic headaches, you must start having these symptoms. And the other one is the continuous light sensitivity, intractable light sensitivity. You are having maybe 5 migraine attacks, but every single 5 migraine attacks in a month, but every single day you have a light sensitivity. It's important because light sensitivity increases the risk of depression and anxiety. And allodynia, you might not have severe headaches sometimes. It's like, I'm not having the headaches anymore, but still you don't feel good. You feel sick, or you have those sensitivity reactions that you don't feel yourself. So it's still important to treat as a chronic migraine, because migraine is not a headache by itself. It's the oldest symptom complex, right? So you still required to have treatment.
Sorry, I have another question.
Sure.
Can you have that for noise as well, the continuous noise sensitivity?
It can happen, yes, unfortunately, yeah. So what are the, what kind of things predict that you can go back to having episodic headaches from episodic migraines from the chronic migraines? So compliance of the preventive medication, being on a preventive medication is found to be very effective to return back to episodic migraines. Absence of allodynia. If someone has allodynia, it will be very difficult to go back to episodic migraines. We have to treat the allodynia. Physical exercise, people who are exercising more found to have, there's high chance that they will return back to episodic migraine. But at the same time, if you're having chronic migraine, it's difficult to exercise, right? When we say exercise, it changes person to person and based on your condition. If you are having severe headaches every time you move, when you have chronic migraine, when you have migraine, you don't like to move, you don't even like to move your head, how you can go onto treadmill and then do exercise, right? So it will be different person to person. So if someone is doing a desk job and they are having chronic migraine, and migraine prevents them to going to the gym or going outside running, we ask them to every hour stand up, walk around the office and come back. It can be a good start. Don't think about like 1 hour exercise. Think about 10 minutes, 5 minutes, walking around the house. Start with walking, not with running, right? Start slow and then see the progress, and then when you feel ready, you can step up the exercise level. And withdrawal of overuse medication. If you are taking a simple analgesic more than 15 days a month, and then the combinations or triptans more than 10 days a month, we talk about medication overuse. If you decrease the amount of rescue medication you are taking, that will also high chance that you can turn into having episodic migraines.
Yeah. What's an example of compliance to migraine
preventive medications?
Yeah,
taking the medications, the preventive medications, the everyday medications, to help to decrease the amount of headaches that you are having, taking it every day. Or if you are having Botox, having it every 3 months, following the therapy, that means that the compliance.
Quick question.
Go ahead.
On the last bullet point, withdrawal of overused migraine rescue meds, is it not so much having the withdrawal from it, but if you taper yourself
Correct.
from
It's
it,
important,
then it
yes.
can help?
Yes, so if you need to take rescue medications, we are not questioning our patients that they are taking the rescue medications too much because they are addicted. It's not the addiction issue. You are taking the medications because there is no other way you can function. There is 2 chances. You will either give up or you will continue, and then you do what you can to move on, right? So that's why you cannot just stop the stop the medication that you are taking or maybe overusing. It's important to support it with preventive medications or other rescue medications, effective rescue medications. And the idea is not to need it. It's not to take it, not to need it. But what happens if you keep taking the like say ibuprofen, you know that it's not helping you, but you are trying to help yourself somehow, and then you keep taking it. There are some functional MRI studies showing that people with medication overuse, they have the frontal area of their brain, it brights up. It's the same area that it's functioning, high functioning with the people who are having addiction problems. It's the good thing is it goes back to normal. It goes back to normal when you stop taking it. Sometimes it's the habituation. It's like you wake up in the morning, the first thing you do, you take your ibuprofen. The first thing in the morning, you take a 2 Excedrin. And what we start when I first talk about the medication overuse with my patients, I like them to think about it before you take it, or think about it before you after you take it. Did it help, or does it really help? Is it really doing anything to you, or is it just you're just trying to help yourself with taking something? Even though they are over-the-counter medications, they are not safe, right? Taking ibuprofen every day, it's a risk for your stomach. It can cause ulcers, GI bleeds. It can cause chronic kidney problems. If you are taking Tylenol every single day, it's a risk for your liver. It can cause liver injury. So over-the-counter doesn't mean that they are safe. They are non-prescribed medications, but there should be a limit how much you take them. Okay? So when we are trying the medications, and then after failing multiple medications, then I sit back and then I think about, am I missing anything here? Is this the right diagnosis? Because different chronic headaches requires different treatments. So then we go back and then talk about again, I ask my patients to describe me your headache again, and then see if we are missing anything here. We looked all the risk factors, like why you are having the chronic headaches, is this, what's the reason for the chronification, and is there any some red flags or other things, why is there anything we are missing, and then we go back to diagnosis. So you can have chronic migraine, chronic tension type headache, hemicrania, new daily persistent headache. Again, there are other chronic headaches that like chronic cluster headaches and other primary or secondary headaches that I did not put here because of the timing, and then I chose these ones that they are very common. Tension type headache. So tension type headache is more common than migraines, but it's less likely to seek for medical attention, because tension headaches that they are mild to moderate severity. They are not as severe as migraines, and the other important findings of the tension type headaches is you can distract yourself. So people who have tension type headaches, like they started having a headache at work, they like to go to gym, they like to take a walk after work. Then they can distract themselves and then headache will go away. When it comes to migraine, it doesn't work that way. You cannot really distract yourself. With tension type headache, you don't get nausea, you don't get sick on your stomach, you don't throw up. Location, usually we think that if a person has a headache back of their head, it's the tension headache. It doesn't have to be back of the head, or not every headache back of the head is the tension headache. You can have a migraine, but your migraine might localize there instead of localizing on one side. Tension type headache, most of the time it's both-sided. It's both-sided, it's not throbbing, it's more achy, pressure kind of feelings. It can be like a bend sensation around your head, and you can have maybe light sensitivity or sound sensitivity, not both of them together, and you don't get nausea. If you are having mild headaches in between your chronic migraine, but you are still having some nausea, and then if you are more active, headache gets worse, that's migraine, it's not tension type headache. So migraine headaches, the minimum duration for migraine headache is 4 hours, except kids or adolescents. They can have 1 hour migraines, but for adults it's a minimum of 4 hours, and it can go up to 72 hours and sometimes even further. And it's unilateral shifting. Shifting means that sometimes it's on the right side, sometimes it is on the left side. You can have 90% on the right, but 10% on the left, or maybe a couple times in a year it's on the left, but it's most likely it's on the right. It's still the shifting. It's important because if it is locked headache to one side, that the diagnosis might be different. And it's usually pulsating or throbbing, right? And it's moderate to severe in intensity. And physical activity makes it worse. If your headache gets worse, or if your headache gets worse with physical activity, or if your headache slows you down, that's more likely migraine than tension headache, okay? And we like a positive family history. It's not like autosomal dominant X chromosome related, not like that. It's not Mendelian, what we call. But there is always a family history, and there are multiple genes that they affect, they causes migraines. That's why we are not doing any genetic testing, because it's not going to help us. Yep.
I have a headache like 24/7. It's sometimes more like a migraine, sometimes more like a tension. But the tension one always has the photo and the phonophobia. And it's always, even when I have a classic migraine, it's always whole-headed. Is that
It makes sense, yes. If you remember, when we talk about the chronification of the headaches, then your headache, some of the presentations can change. Okay. And when you have chronic migraine, it can be both-sided. These are we like some of them together.
Okay.
You don't have to have unilateral, or you don't have to have nausea, but we like a couple of these together. Okay, so you can have a migraine even if your headache is both-sided. And you can have non-migrainous feature headaches in between. It's still you have chronic migraines. When it turns from episodic migraine to chronic migraine, some of the days it's based on because your pain threshold is changing, your sensation to pain is changing, and then some of the symptoms doesn't present as pronounced as it was before when it was episodic headache. Mm-hmm. Hemicrania continua. So there is this group of headaches called trigeminal autonomic cephalalgias, and hemicrania continua is one of from that group, and it's more common in female than male. And this one is a side-locked headache, that you have this continuous headache, and on top of it you have the attacks in between. And the autonomic symptoms means that you have tearing from their eye, you have runny nose, you have droopiness on the eye, swelling of the face, dullness sensation in the ear. These are autonomic symptoms. You can have bilateral autonomic symptoms with migraine. It's very rarely, but it can happen. But if you have one-sided headaches and with these one-sided autonomic symptoms on the same side with the headache, then it's more likely you have one of those trigeminal autonomic cephalalgias, and if you have been having chronic, it's more likely hemicrania continua. Sometimes it can be very subtle that you have this locked headache on one side, never moves to the other side, it's always on that side, and you might have little tearing that you kind of ignore, or sometimes one of my patients, the way I realized it, because she kept showing me that I closed my eye, or I went to a theater and then I had to put something on under my glasses, so I was able to watch it. So it's always on the one side. The light sensitivity also can be on one side. With migraine, the light sensitivity is bilateral. If you get tearing, it's both-sided. With these headaches, it's side-locked headache. Everything is on that one side and doesn't move, doesn't shift. The treatment and the diagnosis is using the medication called indomethacin. When you take indomethacin up to 225 milligram a day, if it helps, then that's your diagnosis. If it doesn't help, then we look into other reasons why you are having that kind of headache. New daily persistent headache. New daily persistent headache is a headache diagnosis. It has been more commonly made last couple years. It's a headache that starts one day and never goes away. It's different than chronic migraine or chronic tension headache, because with those you had an episodic headache, it progressed into the chronic daily headache. But with this, you either wake up one day with the headache and it never goes away, or the headache comes when you are doing something, then it comes and it stays and it never goes away, and you don't get any headache-free time since. And usually the day and date, if I am seeing a patient with this diagnosis, usually they tell me that I started having headaches since March 27, 2012. It's the day that the headache started and it never gone away. Okay, it can fluctuate. The severity can fluctuate. It can be more severe than other days, but it's always there is pain. You wake up with it and you go to bed with it. The pain there is no characteristic presentation of this kind of headaches. It can present like migraine, or it can present like tension type headache. And unfortunately, we don't have any specific treatment for these headaches. We treat it based on how it presented. If it's presented as migraine, we treat it as a migraine because that's how much we can do. And the importance when it comes to workup, that we have to make sure that there is no secondary reason why a person starts having a headache one day and it never goes away. It has to be looked into. If there's any structural disease, neuroimaging laboratories should be done to see if there is any reason why this person started having this headache. And post-traumatic headache. We talk about post-traumatic headache a little bit. So it's the headache that started within 7 days after the injury. If someone had trauma and it caused loss of consciousness, stayed in the ICU for a couple of days, then that 7 days starts counting after the person wakes up, and then within 7 days, if they are complaining about headaches, then it's post-traumatic headaches. And post-traumatic headaches, like the new daily persistent headache, it doesn't have a specific presentation. It can present like chronic migraine, it can present like chronic tension type headache, and again we treat it the way the best way we know is we treat it as a chronic migraine, and we use the treatments for that. And it can be again by itself, the headache presents by itself, or it can be a part of the syndrome, post-concussion syndrome. These symptoms, this syndrome, when someone has post-concussion syndrome, we treat it based on symptomatic treatment, based on the symptoms. If someone having balance problem, dizziness, then we consider physical therapy for balance therapy. If someone is having reduced ability to concentration or cognitive decline, especially with students like they are in high school or middle school, they have problems with their academic performance, the grades goes down. The treatment is focusing on the cognitive ability, that tests like Sudoku or using video games that they can help to use your brain, those kind of things helps to improve it. And if someone has migraine kind of headache associated with these, then treatment of that migraine will help for the other symptoms as well. It usually gets better, but it can sometimes last longer than other times. It can go up to 5 years, unfortunately. Okay. Did I miss a slide? We did not talk about this. I think I passed it. Okay. So there are red flags that we should consider if there is any structural or systemic disease causing these headaches, and we look into more detailed examinations and neuroimagings or laboratory exams. So if someone is having abnormal neurological examination, we can find this during the exam, or you can feel the signs or symptoms of these neurological problems, that you can have weakness doesn't go away, you can have double vision that doesn't go away, or you can have a numbness on one side. If you are having those kind of neurological symptoms, that we have to do an examination and we should consider neuroimaging. Focal neurological symptoms that are not consistent with typical migraine aura symptoms. What's typical migraine aura symptoms? Aura is a neurological symptoms, comes on within 5 minutes and it goes away within 60 minutes. So most commonly it's visual symptoms, visual aura. You see flashing lights, zigzag lines, dots. It starts small, it gets bigger, and then, or if you see the dots, they move around, you cannot see through them. It comes on slow and then it goes away within 60 minutes. If the aura symptoms are not going away within 60 minutes, that it's prolonged aura. If someone is having prolonged aura, we have to be more cautious and think about if there is any secondary reason. Hemiplegic migraine, that you start with the headache, or before the headache you get a weakness on one side of your body, and it's is it the migraine or is it something else like a stroke, right? It's very important to differentiate this, and the patient, the person who is feeling that, that's the person who will explain it, and we can make the we can understand if it is stroke or if it is aura. The difference is stroke comes out of the blue, every symptoms in the same second. If you get a stroke, left side of your head, the brain, and then you get a weakness on the right side, the arm, the face, the leg, they will weak all of a sudden at the same second. If you are having an aura, motor aura, sensory aura, it starts, let's say on the thumb, it moves up, it moves down, it goes to your face, there is a progression. When there is a progression, it's more likely it's migraine. You might get scared, especially with the first episode of hemiplegic migraine. Then you go to ER and you get an images, MRI, and then you get another attack. And you don't want to go to ER every single time. You don't want to get an MRI every single time. Or even if you go to ER, you don't want the images, you just want the treatment because your home medications are not helping. You should be able to tell the doctors in the ER that this is my migraine symptoms, and I know it's my migraine symptoms because there is a progression. This is how it started and this is how it progressed. But at the same time, if someone is having hemiplegic migraines or migraine with aura, their stroke risk is higher than the normal population. So you have to know if you have a stroke, you should go to ER, right? We don't want to miss the stroke, but at the same time.
My question is how are you going to know the difference if you're having a hemiplegic migraine versus a stroke?
Hemiplegic migraine comes and progresses in seconds. The weakness starts on one side and then it moves around. That's hemiplegia. If it will be stroke, it will be same second. All of a sudden, you were sitting on the dinner table, and all of a sudden that you couldn't hold the fork anymore, and then your leg was weak again. You couldn't walk. It's everything at the same time. But the hemiplegia, there is a progression in the symptoms. Okay.
Thank you.
Perfect. And systemic symptoms. If you are having fever, chills, morning stiffness, joint pains, or rash on your face, or weight changes, weight loss, that we should think about some other systemic diseases. Like rheumatologic diseases can cause some of those symptoms. They can cause fatigue, morning stiffness, joint pain, dry eyes, dry mouth, and rheumatological disease can cause more intractable and more chronic migraines, high likely to chronic migraine and then intractable migraines as well. And if we don't treat those diseases, we cannot control the migraines. Or if you are having GI problems, like you keep having diarrhea, you cannot keep the weight on, you keep losing weight, maybe you have a celiac disease. Or if someone having weight loss and then smoking, maybe there's a risk of cancer. And if we don't treat those, then we cannot control the headaches. So it's important to make sure that you talk about those symptoms if you have some of those symptoms. Okay. Rapid increase in headache frequency. If you have been having frequent headaches, all of a sudden you started having chronic headaches, very frequent headaches, and there is no explanation. There is no life-changing event. There is no change on the location. There is no change on your weight. You are not exercise problems, not obesity. There is no medication overuse. We don't really have an explanation for the chronicity. Then we have to be careful. We have to be more cautious if there is any secondary reason that you are having those changes in the headaches. Orthostatic worsening of the symptoms, meaning that when you are laying down, you wake up in the morning, open your eyes, you are feeling good. As soon as you sit up, the headache starts. Or when you start your day, when you move around, then the headaches progress and it becomes worse. As soon as you lay down, you get a relief. You get a relief with migraine when you don't move and you like to lay down, but this is not related to rest. With migraine, you like to get rest. This is related to position. As long as you are laying down, you are good. As soon as you sit up or you stand up, the headache comes. That's a different headache, low pressure headache, and it requires different type of treatments, and we have to look for leak with the images.
What about when you have a migraine and you lay down and it gets worse?
It can be idiopathic intracranial hypertension. So high pressure in the brain can cause worsening headaches when you lay down or when you lean forward. You are tying your shoes, the pressure comes and you cannot do it. We have to make sure that you don't have high pressure in the brain or you don't have IIH, so the tumor cerebri or idiopathic intracranial hypertension. That requires different treatment as well. And exertional worsening of symptoms. This happens with migraine as well, right? When you move around, when you're exercising, it gets worse. But what's important is if it is like a thunderclap headache. So when you have your palpitations, when your heart rate increases, if you get this all of a sudden thunderclap, like very severe headaches, exertion-related headaches, that we have to make sure that there is no vascular abnormalities in the brain causing this kind of headaches. And new onset headaches, like new daily persistent headache, or if you started having headaches after age 40, 50, then we have to make sure that we look into secondary reasons why you started having headaches. For migraine, we like history of headaches early age, like in 20s, before age 30, that it should have started. If you are starting having headache, and especially if starting it one day and becomes every single day, that we have to make sure that we look for secondary reasons why you are having these daily headaches or new onset headaches. And if someone has risk factors, like someone is having stroke early age, some hypercoagulable state, or someone has a cancer, and their headaches became more chronic, then we have to look for if there is any secondary reason, if there is any problem in the brain causing this worsening of the symptoms. Or if someone has lupus and carrying lupus diagnosis for 10 years, but then their migraines became chronic or daily all of a sudden, then there might be some problem with the lupus is getting active again and needs treatment for their lupus, and it will help for the migraine eventually as well. And we talk about overuse of headache medications already, and it can be it's a secondary headache disorder. It's not about the workup, it's about the treatment that we need to get rid of that rescue medication, the overuse medications. Okay, so these are the things that I wanted to say. Oh. And I can get questions.
So I've had migraines since I was about 14 years old.
Uh-huh.
I'm in my 46 now, so I've had them for an extensive amount of time. But in June, I started getting them every single day.
Mm-hmm.
And so we've started, I hadn't been going to a doctor for so long because it's just, the same old diagnosis all the time.
Uh-huh.
So I had one that lasted for 3 days, and my husband was like, and I even went to the ER and got the rescue treatment, still came back. So my husband was like, you find someone or I will. So I started seeing Dr. Henry, and we're now trying Botox. I've had my 2 treatments of that, but I'm still having them every single day. Is that, is that common? Is it not
So
common?
first, what we need to look into why you start having headaches why your headaches became daily all of a sudden in June. Was there any head trauma? Was there any illnesses? Was there any change in your life? Did you have change in job and location? Any problem in the family? Is there any medication overuse?
There is now.
There is now, yes, unfortunately.
There wasn't before, but
yes,
I mean,
yeah. So, and your headaches, they did not progressively worsen and became daily in June, did they?
No, they just I had my average, weekly or bi-weekly headaches.
Mm-hmm.
But then like you say, I remember the day. It was June 21st. I was in California and I got a headache.
And I never
didn't
gonna
have my medication with me because I was just on a one-night business trip. Got home, took the medication, didn't go away. Went to the ER, came back, took medication, laid in bed, and ever since then, they've just been about almost daily. When I first got my first round of Botox, they went away for 4 days straight, and I was like,
perfect.
Whoa, this is amazing.
It takes time. When it comes to Botox, is a great treatment. I love Botox because it's safe. Most of the time it's being tolerated, very less likely to cause any side effects, and it's not something you take every single day. So you go to doctor's office, get your Botox treatment, and you're good another 3 months. But it takes time. After first Botox, you might not have any changes within 7 to 10 days. And when it kicks in, the first thing it does is it decreases the severity of the headaches. And then after second cycle of Botox, then you start having less frequent headaches. The Botox has the cumulative effect, meaning that the more you get it, the more benefit you will get from it. But Botox by itself might not be enough. And before the treatment, you have to make sure that there are, if there was any possible reason, you should have a neurological exam, and you should have a blood test done to look for vitamin deficiencies, thyroid problems, kidney problems, liver problems. If we rule out all of those things, we couldn't find any secondary reason, we continue to do the treatment. But we'll always have in mind that we have to be cautious if we find any change on the presentation in the clinic, that we might look into some of those tests again and then see if there is any other reason why you are having these headaches. But Botox is a good start. And the way I like to do it, and I do Botox is the treatment that kind of goes on the side, that we don't make any changes. It's a standard treatment, right? It's every 3 months. It's a standard injections, and in between, in the meantime, we make the medication changes to see if we can get rid of those daily headaches. And having a good rescue medication is important as well.
So a little off topic, but kind of on that piece of the Botox and using it in like combination therapy with your like daily preventatives. Like I'm on Emovig, and together it's like it helped me get to the most, I mean, I'm still in pain daily, but it's more tolerable. But now, like, insurance is denying combination therapy.
Yes.
So, like, what's
It's a problem.
the hope or the future with?
We are working on it, I can
Okay.
say. So in our division, and headache division here, we are in contact with different companies, the Botox company and the medication companies. They are also working, they have been in debate with the insurance companies, trying to get them convinced that it's safe and this works better, and then there are people that they require both. But the insurance companies, they are asking for evidence. We have been trying to get these companies to help us to start a study so we can show the evidence, and then we can have our patients to be on both medications, and then the insurance can accept and help us as well. But yes, it's a question being asked everywhere, and it needs to be answered. Yep. Any other questions?